My name is Manish Parikh, and I'm from Columbia University Medical Center. And it gives me great pride to be able to present this remotely for Dr. David Ryzik's Scottsdale Interventional Forum 2020. Topic today is the top coronary trials of the past year. And I'll take roughly 20 minutes to review what I think are the most clinically relevant coronary trials which will impact practice moving forward. These are my financial disclosures, nothing relevant with respect to this particular discussion. I want to start off with the very first trial being, I think, very, very important. I got to give Dr. Roxana Moran, our colleague and friend from Mount Sinai, a lot of credit. Twilight. We've all seen this and heard about it. I think it's important to review this briefly because it does impact how we treat our patients with DAPT. So Twilight, as you know, is ticagrelor with aspirin alone in high-risk PCI patients after coronary intervention. The hypothesis that the study investigators had was really to see whether patients undergoing PCI who are at high risk for either hemorrhagic complications or ischemic complications would do better with ticagrelor and aspirin after 3 months, either dropping the aspirin or continuing dual antiplatelet therapy. And what would be the effects with respect to bleeding? And would there be actually a harm with respect to ischemia? The study endpoints, as you see, were primary endpoint were bleeding with a superiority hypothesis, looking at BARC 2, 3, or 5 bleeding events between 0 and 12 months after randomization. And the key secondary endpoints were ischemic and a non-inferiority hypothesis, looking at non-fatal MI, stroke, all-cause death between 0 and 12 months after randomization. The trial proceeds as follows with 9,006 enrolled, 119 randomized 1-to-1 with ticagrelor and placebo versus ticagrelor plus aspirin, and a 15-month visit with very, very high penetrance and follow-up. The study design was as follows. A high-risk PCI patient population was looked at. There were only 1,800 that were not randomized for a number of reasons, either because of bleeding in the first 3 months or ischemic events. And after the first 3 months, they were a double-blind, placebo-controlled trial with one arm receiving ticagrelor and aspirin, and the second arm receiving ticagrelor and placebo. Adherence to medication was at a very high level, and follow-up was also very, very closely done. If you look at the data here, very interestingly, at 12 months, the BARC 2, 3, or 5 bleeding in the ticagrelor and aspirin arm were higher than that of the ticagrelor and placebo arm. And the question really is there a penalty to pay with respect to ischemic events with reduced bleeding events? Here you see the key secondary endpoint of death, myocardial infarction, or stroke. And here, ticagrelor and aspirin at 12 months had a rate of cumulative incidence of 3.9%, similar to that of ticagrelor and placebo. Hence, marked reduction in bleeding with no ischemic increase in complication rate with a single agent of ticagrelor alone. Again, here you see that landmark analysis, as well as from 12 to 15 months, whether there was any difference in ischemic events, and there was not. So the summary and conclusion for Twilight is that in high-risk patients who underwent PCI and were treated with ticagrelor and aspirin for 3 months without any major adverse bleeding or ischemic events, an antiplatelet strategy of continuing ticagrelor monotherapy resulted in substantially less bleeding than ticagrelor plus aspirin without increasing ischemic events over a period of 1 year. Our second clinical trial, which I think is relevant brings up a very, very important aspect of clinical care in the interventional community. And I want to highlight this because it makes me very proud to see one of our former fellows, Evan Schlafmitz, along with his team down at Washington Hospital Center with Ron Waxman, who put out this particular paper, looking at the impact of intravascular ultrasound on outcomes following PCI for ISR, in-stent restenosis. Again, the background, as we all know, is that PCI for ISR remains common despite the advancements in both stent technology and technique. And imaging, which has been a bugaboo for us in the United States, imaging-guided PCI is associated with a reduction in adverse events after PCI, but yet penetrance in the clinical community is low. Intravascular imaging allows for the determination of the mechanism of ISR and guiding appropriate therapy. And hence, I think for what we are seeing clinically in our practices with DES ISR, imaging, specifically with IVUS, is rather important. So the hypothesis was that for the treatment of ISR, IVUS would be associated with improved outcomes. Very simple hypothesis. All patients at 1 year follow-up were treated with PCI of complex lesions at the Washington Hospital Center between 2003 and 2016. The sub-analysis was assessed. Primary endpoint was the rate of adverse cardiac events, or MACE, at 1 year, defined as composite of all-cause mortality, Q-wave myocardial infarction, and target vessel revascularization. And here's the study flow with over 1,000 IVUS guided and about 519 patients angiographic guided alone. And if you look at the 1 year MACE estimated events rates, no surprise, as we've always known, intravascular ultrasound related or guided therapies for this subcohort of in-stent restenosis fared far better as we went out to a year mark with respect to the cumulative incidence rate. Temporal trends in PCI for ISR in the United States continues to be south of 20%. And I think that we are actually doing our patients a disservice by not utilizing imaging, especially for some of our more complex subgroups of patients. So the results here are very simple. Over 1,522 patients analyzed, about 66% had imaging, about 34% had angiography alone. Post-dilatation was used more often with imaging, with larger stent diameter, but without a difference in stent length. Primary endpoint occurred in 18% of patients with intravascular ultrasound, and about 25% of patients treated without IVUS. And at 1 year, target vessel revascularization occurred in 14.5% with IVUS guidance versus 19% in the angiographically alone guided group. And the estimated adjusted hazard ratio was significant at 0.77. Again, leading to the discussion about why we're underutilizing intravascular imaging in our patients, in this particular case, IVUS, for patients with in-stent restenosis. The conclusion here is the use of IVUS is associated with decreased MACE. Routine IVUS in a complex patient cohort is safe and feasible, and these results do support routine imaging utilization for the treatment of in-stent restenosis lesions. The third topic I want to discuss, which I think has significant impact on our coronary algorithm as we move forward, is this particular trial. I'll give Ziad Ali from our institution at Columbia a lot of credit. This was safety and effectiveness of the coronary intravascular lithotripsy for treatment of severely calcified coronary stenosis. This was the Disrupt CAV to OCT substudy. And the reason I picked this is that a lot of mechanical devices have come out, but I think it's very important for us to be thoughtful in our approach and to understand the mechanisms of action and what devices or therapies do work and give us meaningful positive results. So this particular study looked at intravascular lithotripsy. And clearly we know that calcium in the coronary is a bugaboo. It is a challenge. It is more progressive. We're seeing this in our aging population, patients that are diabetics, patients with renal insufficiency. And we know that plain old balloon angioplasty just doesn't do it with respect to expansion. We've gone to some more aggressive atherectomy devices, which we are finding useful. At times we can use devices like laser, which also has interesting and unpredictable results. And these are the types of patients that we're really talking about. This is a right coronary where you can see a cast of calcium in the mid portion, train track calcium. These are the types of cases that you almost want to run away from. Yes, there are many different techniques, but to get a result like what we see here with a very simple device called lithoplasty is, I think, very interesting to look at. So what is coronary intravascular lithotripsy? It's a high-speed sonic pressure wave created inside an integrated balloon. Essentially, you have a balloon with an unfocused lithotripsy energy, which is created by emitters, which are contained in a fluid-filled coupler. And an electrical energy is delivered circumferentially by the balloon to the emitter, initiating a steam bubble, which actually causes a very high pressure and focused expansion of the coronary anatomy where the device sits. The video actuation of a single pulse is here, and you can actually see what happens as you initiate these emitters and provide pulse waves. So if you look at this from the inside of a coronary, and this is a beautiful OCT depiction, a lot of our patients have circumferential calcium. There are many different calcium morphologies for sure, but this type of circumferential calcium, as in the panel on the left, with an arc angle of over 300 degrees, can be challenging to treat. Bottom line is, in order to obtain expansion of our stents, we need to cause or create circumferential calcium fracture. And the question really becomes, is calcium fracture possible during these types of IVL therapies? And if so, is it working where it should be working? So the Disrupt CAD2 OCT sub-study really looked at that with 120 patients. And I'm going to show you this. 47 patients have been completed. So I looked at stable or unstable patients, or patients with silent ischemia, with heavily calcified coronaries, with diameters between 2.5 to 4 millimeters, with lesion lengths less than 32 millimeters, and circumferential heavy calcium, and clear significant stenosis. And the objective was to determine the mechanistic effects of lithoplasty on heavily calcified coronaries, and look at the frequency of calcium fracture, and then secondary endpoints look at the multiple fractures, fractures per lesion, fractures per length, depth, maximum calcium thickness, and angle of fracture site. And what we found, interestingly, and what Ziad reported, is that in these 47 patients, there were multiple fractures in a good percentage of them, with really appropriate fracture at the heaviest density of calcium. And that's the most important thing to remember about this particular therapy. And that's exactly what we look for in treating our patients with heavily calcified coronary disease. So here's a representative example, pre-PCI on the top, post-PCI on the bottom, looking at both the proximal, maximal calcified and distal vessel, and looking at appropriate stent expansion after treatment with lithoplasty. And clearly you have beautiful stent area expansion because of appropriate calcium fracture in the calcified segment that we're looking at. If you look at the lumen area, both pre-IVL and post, and the calcium angle clearly see marked benefit after treatment with IVL. Included in that is the final MSA for the site. And the safety, which has always been a concern, is, are these procedures with lithoplasty going to be safe? Are we going to have higher dissections, higher perforations, higher no reflow? The answer is not likely, as long as it's done in a careful manner. So in conclusion, simple as this was, I thought it was an important mechanistic sub-study to highlight a therapy which I think in the future is going to be very clinically relevant for us practicing coronary interventionalists. Clearly, the predominant mechanism of action of intravascular lithoplasty is calcium fracture. We identified that in a large percent of these patients. And the most important thing in calcium is to appropriately expand our stent so that we can get lumen areas that have meaningful duration and low complication rates for our patients. And this is exactly what this particular trial showed. And finally, moving on to the ischemia trial. The ischemia trial is, I think, a relevant and important topic to talk about as interventional cardiologists. It was the hit for the AHA. It's the international study of comparative health effectiveness with medical and invasive approaches for coronary, stable coronary and ischemia. So the research question that was really being entertained was, what is the best initial management for patients with stable coronary disease and at least moderate ischemia? Is it an invasive therapy with optimal medical therapy, or would it be acceptable to potentially try a conservative therapy looking at optimal medical therapy? So here is the protocol, which you've all seen. This is stable patients with moderate or severe ischemia determined by a core lab. They were then subsequently blinded to a CTA. The core lab anatomy was eligible if it was not left main disease. CCTA was not required if the GFR was less than 60, less than 30. And then the patients were randomized to either an invasive strategy with cardiac catheterization and revascularization, or a conservative strategy. And an average of 3.5 years of follow-up was maintained with the primary endpoint of composite of cardiovascular death, MI, resuscitated cardiac arrest, hospitalization for unstable angina, or heart failure. And this key secondary endpoints was cardiovascular death, or MI, and an angina quality of life survey was also taken. So the baseline characteristics of the 5,179 randomized patients showed that there was a diabetes rate of about 41%. Stress imaging was performed in 3/4 of the patients. The angina classification was that of 90% of the patients with weakly angina and about 20%, which I would have thought would be higher, but the median was a score of 80. The core lab interpretation of stress test, as you see, severe, moderate, mild. You see that imaging was taken in about 90% of these patients, and severe was seen in 83% of the patients with exercise treadmill testing. If you look at the data with cardiac catheterization and revascularization, here you see the data in this particular slide, looking at both the invasive arm and the conservative arm, and following this up over 5 years. You also see the revascularization versus the conservative arm, looking at the cumulative incidence here as well over 5 years. The mode of revascularization, first procedure for those revascularized in the invasive group, approximately 80% of them was an invasive procedure. 93% of these patients had successful stents placed, of which 98% were drug-eluting stents. 26% of these patients underwent coronary artery bypass grafting with predominantly arterial grafts. Of the approximately 20% with no revascularization, 2/3 of these had insignificant disease on coronary angiogram, and 1/3 had extensive disease unsuitable for any mode of revascularization. And if you look at the primary outcome of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest, here what you see in the conservative arm versus the invasive arm, fairly equal numbers out to 5 years with the adjusted hazard ratio of 0.93. And you see absolute differences in both the invasive versus conservative group of roughly 2.2% at 4 years. Major secondary outcomes of cardiovascular death or myocardial infarction, again, 13.9% versus 11.7% at the 4-year mark, looking at cumulative incidence. If you look at procedural MIs, what we call type 4A or 5 MIs, again, adjusted hazard ratio of 2.98 over 5 years, slightly higher in the invasive versus the conservative group. And if you look at spontaneous MIs, which we're always worried about, looking at types 1, 2, 4B, or 4C as they were classified, slightly higher in the conservative group with the adjusted hazard ratio of 0.67. Now, the most important, if you look at cardiovascular death, here you see out to 4 or 5 years, a adjusted hazard ratio of 0.87, with the conservative being slightly higher than the invasive group, but again, a p-value of 0.33. So what did ischemia tell us, and what did it not tell us? Well, the important thing to remember is, yes, these are a specific group of patients. Yes, they were stable. Yes, they had moderate ischemia, but the full power cohort for death or MI cannot be made, and these patients were not enrolled. Patients with acute coronary syndrome were not enrolled. Patients with left main disease were not enrolled and disqualified. Patients with ejection fractions that were reduced were not enrolled. Patients who had severe symptoms, were refractory to medical therapy, clearly an average angina was only monthly, were not enrolled. So hence, what this data is suggesting is, yes, perhaps in the patients with moderate ischemia, moderate angina, there may not be a rush for these patients to run to the cath lab and get revascularized, as long as they do not have reduced ejection fraction and left main disease, and as long as they have optimal graduated medical therapy, which, as we know, is not always the case. Clearly, we do know that the quality of angina was improved in the patients with an invasive approach in those who were refractory to graduated medical therapy. But we are learning that the impact of stable angina is really that about patients' lifestyle and not that about prognosis, unless they really have severe multivessel disease along with left main disease. Our goal for therapy in stable ischemic heart disease is to improve prognosis and to improve symptoms and quality of life. And I think the ischemia trial is just yet another example of how we need to be thoughtful in our approach with patients with stable ischemic heart disease and manage these patients with appropriate graduated medical therapy. Really, as a summary, I'd like to end with this. Clearly, the symptoms are moderate to severe revascularization, might be concerned and be appropriate if patients' exercise capacity are reduced, or their clinical risks are severe or high, or their anti-anginal drug tolerance is poor, and their revascularization risk is low, and their tolerance or adherence to DAPT is low. Still, at this point, I think appropriate guided revascularization is still the method of choice for us in interventional cardiology. And with that, I will stop, and I want to thank Dr. Reisig and the coordinators for inviting me for the Scottsdale Interventional Forum.